Om Swastiastu, we are from Group B6 and we will present our student project about Juvenile Idiopathic Arthritis. Now we will present the introduction to the first presenter in charge. You may start.
Hello, my name is Kadek Bintang Aristia Putri with my digital master number 056 and I will explain about the background of this paper. Juvenile Idiopathic Arthritis or GIA is the most common pediatric rheumatological disorder. The term idiopathic means that the cause of this condition is unknown and it is thought to be related to autoimmune dysfunctions. GIA usually affects children younger than 16 years old and lasting 6 weeks or longer and commonly affect females than males. In GIA associates all form of chronic childhood arthritis affecting not only joints but also extra articular structures including skin, eyes, and internal organs, causing associated disability and even death. Research on GIA has been ongoing for several decades, and due to the large number of adverse effects from treatments, it is necessary to require a monitoring regimens and patients' educations. If treatment is not implemented, it will result in increased morbidity due to significant disease progressions and will have an impact on the quality of life of affected children. The problem formulations of this paper is what is the definition of juvenile idiopathic arthritis, what is the epidemiology, etiology, and pathophysiology of juvenile idiopathic arthritis, what is the differential diagnosis of juvenile idiopathic arthritis, and what are the treatment and management of juvenile idiopathic arthritis. That's all from me, and the next slide will be presented by my friend. Thank you.
I'm Angelica Fortuna Ongawan with the last 3 student digit number 092. The objectives of this paper are to describe the definition of juvenile idiopathic arthritis and also explain its epidemiology, etiology, pathophysiology, differential diagnosis, treatment, and management. There is theoretical benefit of this paper. This paper can be used to increase knowledge about juvenile idiopathic arthritis, its epidemiology, etiology, and pathophysiology. In addition, it can add insight about the treatment and management of juvenile idiopathic arthritis theoretically. There is also practical benefit for readers. These papers are being a source of information regarding juvenile idiopathic arthritis. For writers, it's to increase the experience and knowledge in writing scientific works. For academic institutions, it can be used as a reference to develop knowledge about juvenile idiopathic arthritis.
Hello everyone, my name is Nadia Aprilia Sisyanti with 3 last digits of student number 229. Will explain about the epidemiology. All chronic inflammatory arthritis of unknown cause that first manifests at age 16 or younger is included in GIA. Estimates of the frequency of GIA range from 1.6 to 23 cases per 100,000 people, for example, with significant regional variation. The most prevalent rheumatic disease in children from Western countries is GIA. Depending on study methods, illness category, and geographic regions, the incidence and prevalence range from 1.6 to 23 new cases per 100,000 children and 3.8 to 400 cases per 100,000 children respectively. The frequency of GIA, estimate at 3.8 to 400 per 100,000, was reported to be closer to the lower end of the global estimate across Africa and the Middle East. The majority of GIA subtypes are predominantly female. That's all about the epidemiology. Thank you.
First of all, my name is Devaline Ramadhan with 3 last number 060. The etiology of juvenile idiopathic arthritis or GIA is not fully known, but in individuals with genetic susceptibility is potentially instigated by environmental stimuli, including infectious agents. Despite variance in research finding influenced by ethnicity and culture in distinct regions, a multitude of studies corroborate the implications of infections in the indications of potentiation of GIA race. Genetic predispositions, including specific human leukocyte antigen or HLA markers, and polymorphisms play a role in the susceptibility of GIA. Environmental factors such as infections may trigger the condition in individuals with genetic predispositions. Dysregulation of the immune system, including an abnormal immunity response to self-antigens, contributes to the development of GIA.
Greetings, doctor. My name is Chen with the last three-digit number 119, and today I'm going to explain about the etiology of GIA concerning to epigenetics. So, GIA may be acquired due to the combination of genetic and environmental factors. DNA methylation is essential to regulate gene expression, whereby its irregular alteration has been found to drive adult autoimmune rheumatic diseases such as RA. The study of epigenetics in pediatric autoimmune rheumatic diseases like GIA hasn't been much done. However, some have proven its correlation to the methylation of DNA and histone protein. A single differentially methylated position, or DMP, was detected in GIA cases, indicating DNA methylation to happen at the CPG site. Alteration of epigenetics was found to occur at the site of cytosine encoding in layer sequence. In addition to that, a more highly methylated CPG site was found in GIA cases compared to the control population, which in this case contributed to the clinical outcome of GIA with irregular functioning of CD4 T cells.
So hello everyone, my name is Adellya Pramesty with my last three-digit number 165. So here I'm gonna explain about the definition. Historically, juvenile idiopathic arthritis was discovered by Frederick Still in 1896, so it was called as Still's disease. Then by the development called as juvenile chronic arthritis or juvenile rheumatoid arthritis. However, in 1980 the term changed into juvenile idiopathic arthritis because juvenile chronic arthritis and juvenile rheumatoid arthritis are described as adult arthritis condition that occurs in children. So according to the etymology, the words that make up juvenile idiopathic arthritis can be explained as juvenile, that comes from the Latin words juvenile, meaning young, which connoting children. Idiopathic, that comes from the Greek word idios, or meaning one's own, and pathos, that means suffering, meaning illnesses of their own kind, or clinically described as conditions with unidentifiable cause. And arthritis, that comes from the Greek word arthron, which means joint. Thus, the terms that make up juvenile idiopathic arthritis can be described as a condition with unknown cause that attacks children's joint.
Right, so let me continue explaining about juvenile idiopathic arthritis or GIA. So GIA often affects children under 16 years old and lasts for at least 6 weeks. Since 1995, juvenile rheumatoid arthritis or GRA and juvenile chronic arthritis or GCA have been replaced by the term juvenile inflammatory arthritis or GIA. So when we refer to chronic arthritis in children, we say that a GIA, not a GRA or GCA. So there are 7 GIA classifications according to ILAR. These classifications include oligoarthritis, polyarthritis, mediated by rheumatoid factor, polyarthritis mediated by rheumatoid factor, systemic arthritis, psoriatic arthritis, arthritis associated with enthesis, and undifferentiated arthritis.
Greetings, my name is Aryanda Maitri Anjasrini with the 3 last digit of student ID number 188. So majority of GIA subtypes shows that the pathophysiology of the disease starts when there is an imbalance of regulatory T cells, especially in T helper 1 and 17 in adaptive immunity. Interleukin 17 then produce pro-inflammatory cytokines and matrix metalloproteinase that leads to joint damage in oligoarthritis, polyarthritis, and psoriatic arthritis. For the systemic GIA is considered as systemic autoinflammatory disorder that comes with episodes of systemic inflammations triggered by irregular innate immune response and excessive productions of inflammatory cytokines like interleukin 1, 6, and 18. For the oligoarthritis and polyarthritis is triggered by the abnormal adaptive immunity with a specific genetic background, as well as environmental factors and individuals' immunological background. The ultimate consequence is an autoimmune syndrome where the immune system targets self-antigens derived from the cartilage, resulting damage in joint, articular cartilage, bone tissue, and formations of pannus by proliferations of synovial cells. The last one is psoriatic arthritis, which is the combinations of HLA-CW6 alongside genetic variations in autoimmune disease-related genes like MEFP, NLRP3, and OD2 or PSTPIP1 that is cited as potential factors of developing psoriatic arthritis.
Thank you for the time. My name is Sara Putri Bungaran with 078 as the last three digits of my student number. And this time I'll explain about the differential diagnosis of JIA. The differential diagnosis of JIA itself is musculoskeletal related diseases, and the clinical manifestation and subtypes of JIA strongly influence the differential diagnosis of JIA, which has a broad spectrum. The first subtype is oligoarthritis. Localized joint pain that worsens with activity and decreases with rest is usually experienced by patients with oligoarthritis. The differential diagnosis of this type of JIA is inflammatory arthritis. If the joint pain includes the wrist, elbow, ankle, or shoulder, OA is unlikely to occur without certain risk factors such as a history of injury. Suspicion of inflammatory arthritis, such as rheumatoid arthritis, should be present if stiffness is prolonged for more than an hour. Oligoarthritis also need to exclude post-streptococcal reactive arthritis, scurvy, Lyme arthritis, reactive arthritis, and the other. And the second subtype is polyarthritis. Not only should rheumatic disease be considered, but also malignancies, infectious diseases, and even medication can cause polyarthritis. Polyarthritis needs to exclude systemic lupus erythematosus or SLE because arthritis can appear in SLE patients. In addition, thrombocytopenia can also be found in SLE patients, and arthritis is also found in acute lymphocytic leukemia patients, so this disease must be excluded as well. Severe joint pain is also present in patients with acute rheumatic fever and osteomyelitis, and polyarthritis should be also excluded from Lyme disease, Sjogren's syndrome, Blood syndrome, and Fabry disease. And maybe that's all for me. For the next speaker, time is yours.
Good morning, Doctor. My name is Gabrielle Femberstafita with my last three digits in the number being 118, and today I'll be continuing about the differential diagnosis of GIA. Systemic arthritis is one of a type of GIA. However, the clinical manifestations and management of the disease are all different. The main difference of SGIA lies in its characteristic as autoinflammatory disease as well as autoimmune disease. According to International League of Associations for Rheumatology, the clinical manifestations includes fever for at least 3 consecutive days, followed with arthritis in one or more joints for at least 6 months and accompanied by one or more of the symptoms such as lymphadenopathy, splenomegaly, hepatomegaly, and serositis. Next, enthesitis-related arthritis is a type of GIA which includes those with enthesitis and arthritis, inflammatory bowel disease, and juvenile ankylosing spondylitis. According to International League of Association for Rheumatology, the clinical symptoms is defined as enthesitis and arthritis for more than 6 weeks in children aged below 16 years old, or enthesitis or arthritis along with 2 of these following symptoms, such as inflammatory spinal pain or tenderness in sacroiliac region, anterior-UVTs, HLA-B27 positive, and family history of HLA-B27 positive. However, the diagnosis of ERA mainly focus on its clinical finding as there are no confirmatory medical tests. That would be all from me. Thank you.
Let me introduce myself. My name is Samantha Petronella Theobald with last 3 student numbers 108. So for the treatment and management of GIA consists of pharmacological and non-pharmacological treatment. For the pharmacological treatment, the first one is NSAID. The NSAID is the first choice for all GIA types early treatment. It inhibits the prostaglandin production, resulting in analgesic and anti-inflammatory effects. Treatment trials are recommended for every type of GIA treatment due to possible adverse effect of the drug use. The second one is DMIRD. The recommendation are MTX, leflunomide, and sulfasalazine. MTX is the first choice for oligoarthritis and PGIA treatment in case of insufficiency of NSAID and steroids. Leflunomides used as an alternative for MTX sensitivity, and sulfasalazine used for moderate activity of ERA-GIA accompanied by peripheral arthritis. There's also biologics, such as TNF-alpha inhibitors, known as effective drugs for treatment for GIA, usually combined with MTX. There's also other biologics that can be used as GIA treatment option. There's also corticosteroids injection on joint are provided to be effective on treating GIA. High-dose corticosteroids give a good short-term effect without long-term outcome. Severe side effects are associated with long-term use of corticosteroids. Oral administered of corticosteroids is not recommended for systemic GIA without MIS early treatment. Recent research suggests combination of DMIRD, corticosteroids, and the biologics result in low activity of the disease. Biologics in early treatment is recommended for controlling disease and reducing steroid use. Opportunistic infection risks are found to be increased on the long term of use of biologics. Aggressive treatment in the initial treatment was found to be beneficial. And there's also non-pharmacological treatment, such as physical therapy, supportive therapy, psychosocial therapy, and surgery that might be needed. Physical therapy focuses on fixing the range of motion without causing any further stress on the joint. The exercise is oriented on fitness, flexibility, and strengthening.
My name is Putu Nadia Anandita Prasanthi, and my last 3 digits to the number is 150. In conclusion, juvenile idiopathic arthritis is an autoimmune condition affecting children under 16 years old with joint symptoms lasting for at least 6 weeks. While the exact cause of this condition remains uncertain, it is believed that this is result from a combination of genetic predisposition and environmental factors. However, the majority of these condition subtypes demonstrate that the pathophysiology of the disease begins when there is an imbalance of regulatory T cells, T helper 1 and T helper 17. This imbalance triggers the production of pro-inflammatory cytokines and matrix metalloproteinase by interleukin 17, leading to joint damage. Conditions with symptoms similar to juvenile idiopathic arthritis included oligoarthritis, polyoarthritis, systemic arthritis, and enthesitis-related arthritis. Treatment and management options for this condition encompass pharmacological approach such as NSAID, DMARDs, biologic, and corticosteroid, as well as non-pharmacological approach like physical therapy, supportive therapy, psychosocial therapy, and surgery. Understanding juvenile idiopathic arthritis is vital for parents and healthcare professionals. This autoimmune condition affecting children's joints requires recognizing its various subtypes and considering a wide range of differential diagnoses. To provide the best care, collaboration among parents, healthcare providers, and specialists are needed. Early diagnosis and personalized treatment are key to enhancing the prognosis and quality of life of children with juvenile idiopathic arthritis. That's all about our presentation. Thank you for the attention.
We have come to the end of our group presentation. Thank you for the attention. Para Santi, Om Santi Santi Santi.